In the triangles of neck, not everything. I mean, it's not the time that you sit down and read about all the triangles of neck and everything. But when you just look at the questions of the previous year, there are two nerves. There are two important nerves on which repeatedly the questions are asked. On the clinical questions are asked here. So let me very quickly draw it for you guys. Let's say if this is a side of the head and neck you're looking at. Here is the base of mandible. This is external auditory canal, the mastoid process, and the occipital bone. So you're looking at the side here. So it's like the base of mandible, external auditory canal, mastoid process, and occipital bone. That's an anterior midline of the neck. That is a posterior midline of the neck. Here we have manubrium, and there is the clavicle. Okay. The triangles of the neck are divided by the two main muscle. One is sternocleidomastoid and then one is trapezius here. So guys, let's say this muscle here is sternocleidomastoid. It is attached to the mastoid. It is attached to the nuchal line also, and below you can see it is attached to the sternum as well as clavicle. The two heads are there, sterno and clavicular head. And the muscle which is present posterolaterally is trapezius. Now for my discussion, I just need these two muscles here, guys. This muscle here, let me just highlight that. This muscle is sternocleidomastoid. And the muscle that you see here is a trapezius muscle. Let me label it here. That is sternocleidomastoid and that is trapezius. See, there is one content. This triangle here is a posterior triangle, right? That's a posterior triangle. And that triangle here is an anterior triangle here. Now, as I said, we just have to discuss a relevant things here. In the posterior triangle, the clinical questions are usually targeted on this posterior triangle because we have subclavian artery, we have brachial plexus present there, we have spinal accessory nerve. So we have some major contents in the posterior triangle. One important content of posterior triangle is a spinal accessory nerve. Now, spinal accessory nerve will enter like this, will pass deep to the sternocleidomastoid and supply it, and then ultimately it will go like this and supply the trapezius muscle also by passing deep to it and supplying it as well. So that nerve, guys, here is the spinal accessory nerve, which you can make out from this. That is a content of posterior triangle. It is a content of anterior triangle also, but I need to focus on the posterior triangle. I'll tell you why. And one important nerve which I wanted to remember, which is present in the roof of posterior triangle, this nerve will be seen emerging from the posterior border of sternocleidomastoid. It runs on the sternocleidomastoid and will go above. This nerve is a cutaneous nerve which is present in the roof. It is present in the roof, and that nerve is called as the great auricular nerve. Now you will realize when you solve the questions that when it comes to questions in the triangles of the neck, their favorite target are these two nerves, and especially the great auricular nerve. Like in the last 5 years, guys, this great auricular nerve has been asked over and over and over again in a different format. But this is the nerve that love asking here. Let me deal with the great auricular nerve first, guys. See, great auricular nerve, it's a branch which you can see is running in the roof of posterior triangle. Then it passes superficial to sternocleidomastoid and goes above here. First of all, this great auricular nerve, the root value is C2 and C3, and it is coming from the cervical plexus. There are some important points about the great auricular nerve to be noted on which the questions are asked. Now, number one, this great auricular nerve in the neck, it runs with external jugular vein. That is the way the NEET have asked this question earlier, that which nerve runs with the external jugular vein on the side of the neck, and that is the great auricular nerve. It's not greater auricular, it's great auricular nerve, guys. Great auricular nerve runs with the external jugular vein. One. Second important thing about this nerve is this nerve goes above and supplies the skin of the lobule of the ear. That was an AIIMS question, guys. This nerve supplies the lobule of ear. It supplies the lobule of ear. Lobule, that means entire lobule of the ear is by this nerve only here. Lobule means the lower 1/3, right? This nerve also supplies the skin at the angle of mandible and the lower parotid region also. This nerve supplies the skin at angle of mandible, and lower parotid region. Lower parotid region. So this nerve is running here. It is coming to this parotid gland region, lower parotid region. Another important piece of information here, see, we all know that in parotid surgery, the most common nerve injured is the one which supplies it. And which nerve supplies it? It's the auriculotemporal nerve. So let us say the auriculotemporal nerve which is supplying the parotid gland is injured. Now during the regeneration, what happens is sometime the fibers of auriculotemporal nerve, they accidentally join with some nerve in this region here. And most commonly it joins with great auricular nerve here. What I'm saying is that in Frey syndrome, the regenerating auriculotemporal nerve, if auriculotemporal nerve is injured in the parotid surgery, so the regenerating auriculotemporal nerve, it accidentally fuse with what now? With the great auricular nerve. Now most commonly it fuses with the great auricular nerve. That doesn't mean it can only fuse with great auricular nerve. The auriculotemporal nerve can fuse with any other nerve in this region here. Now most commonly with great auricular nerve, a little less commonly with a buccal nerve. It can fuse with the buccal nerve branch of mandibular. Buccal nerve, which is a branch of mandibular nerve. And it can fuse with a lesser occipital nerve also, which is supplying the skin behind the ear. In the Frey syndrome, guys, you must have seen the patients that having a salivary stimulus, they also have a sweating on the cheek, on the parotid region or behind the ear. So it depends that the question is asking you where here. If the question simply says that auriculotemporal nerve most commonly fuse with which nerve in the Frey syndrome, so it's great auricular nerve. Or maybe the question has given you the specific site that after the parotid surgery, it is seen that patient is sweating, let's say behind the ear. If you see a sweating behind the ear, that means which nerve the auriculotemporal nerve is fused with? It is fused with the lesser occipital nerve. If he is sweating on the cheek part or very much on the anterior part of the cheek, that means it is fused with what nerve? Buccal nerve. But common scenario is it most commonly fused with what? Great auricular nerve. Now recently how they changed this question, guys, recently there was a question, and see the language of question, how it matters so much. The question in the kind of a very recent exam only was that after the parotidectomy, after the parotid gland was removed, the patient found out sensory loss on his face while shaving. While shaving is an important word here, because the people who did not pay attention to the word while shaving, they answered it wrong. So question was basically that a patient discovered a sensory loss on his face while shaving after the parotid surgery, after a couple of months after the parotid surgery. So it is because of which nerve involvement here? Now we know that in parotid surgery, the most commonly injured nerve is auriculotemporal nerve. Auriculotemporal nerve is most commonly injured in parotid surgery. But that doesn't mean auriculotemporal is the only nerve which can get injured here. The other nerves which also can get injured here, like great auricular nerve can get injured, the facial nerve can get injured here. And because the question said that patient discovered the sensory loss while shaving, so auriculotemporal nerve cannot be the answer to that question, because auriculotemporal nerve is supplying the skin here in the temple region and the auricle region here. That's not the shaving area, guys. Shaving area is here. And this shaving area, that's a parotid part and the angle of mandible, is supplied to what nerve? The great auricular nerve. So in the parotid surgery, even the great auricular nerve can be injured here. In the parotid surgery, the great auricular nerve can be injured here, although it is not the most common nerve to be injured, that is auriculotemporal nerve. But because the question was very specific that the patient felt a sensory loss or found out a sensory loss while shaving, so auriculotemporal nerve cannot be the answer. The answer has to be the great auricular nerve. So please pay attention to the questions like these. The language of questions like these is very, very important. So these are some questions, guys, which can be asked on the great auricular nerve, or repeatedly asked. Spinal accessory nerve. See, what is important in spinal accessory nerve is, and what mistake which we commit usually. We all know that this spinal accessory nerve is supplying two muscles. The spinal accessory nerve is supplying two muscles. It supplies sternocleidomastoid and it supplies trapezius muscle. We all know that, right? Whenever the question says that there is injury to the spinal accessory nerve in posterior triangle, while removing the lymph node or the neck dissection, whatever it is, guys, if there is any injury to the spinal accessory nerve in the posterior triangle, then you have to remember one thing, that it has already supplied the sternocleidomastoid. It has supplied the sternocleidomastoid and then it is injured. And now it is going to supply the trapezius. So when the injury is to spinal accessory nerve in posterior triangle, which muscle will be spared? The sternocleidomastoid will be working. It will not be affected because it is supplying the sternocleidomastoid and then coming into the triangle here. So guys, directly or indirectly, if a question targets to the injury to spinal accessory nerve in posterior triangle, do remember that sternocleidomastoid will be spared. And it's the trapezius muscle which will be involved. And if trapezius muscle is involved, so there will be only, the patient will only show the features of the trapezius muscle, not the sternocleidomastoid. Like, what are the features of trapezius muscle? The function of trapezius is what? Like shrugging of shoulder. So there will be difficulty in the shrugging of shoulder. Middle fiber of trapezius is for the retraction. So patient will have a difficulty in retraction of scapula. Trapezius, along with serratus anterior, it helps in the overhead abduction. They rotate the scapula, so they help in the overhead abduction. Patient will also have a difficulty in overhead abduction. And there will be mild winging of scapula also, guys. Although you will say that winging of scapula is because of serratus anterior and long thoracic nerve, which is true, but even the trapezius involvement can lead to the winging of scapula to an extent. So trapezius involvement will be there, and that will lead to the following features. It will lead to the difficulty in shrugging of shoulders. There will be difficulty in retraction of scapula. Difficulty in retraction of scapula. There will be difficulty in overhead abduction. Difficulty in overhead abduction. Sometimes they give it a case like a patient is unable to comb his or her hair. Now to comb the hair, obviously you have to do the overhead abduction. You have to take your hand above the shoulder here. So you cannot comb your hair because your overhead abduction is not possible, and that is again because of either serratus anterior injury or because of trapezius. And there will be mild winging of scapula also. As I said, winging of scapula is mainly because of long thoracic nerve and serratus anterior muscle, but even trapezius muscle is responsible for keeping the scapula along with the rib cage here. So if your trapezius is paralyzed, the scapula will pop out a little, so that can again lead to the winging here. So difficulty in shrugging, difficulty in retraction, difficulty in overhead abduction, and winging of scapula. These will be the features of the patient who will have spinal accessory nerve injured in the posterior triangle, and no features of sternocleidomastoid. Like the sternocleidomastoid function is what? To turn the head to the opposite side, the lateral flexion of neck. So all this is fine because sternocleidomastoid is working very well. It's only the trapezius muscle which is involved. So guys, as per my suggestion, I would say in the triangles of the neck, these are the two nerves you need to keep your sharp eye on. And especially out of these two, I would say especially the great auricular nerve here. The questions are in different forms, sometime about parotid surgery, sometime about what nerve is supplying the lobule of the ear. Could be anything. Would you imagine, in fact, they even asked this question once, that if the trigeminal nerve is injured, not the trigeminal nerve, it was like there is a tumor in the Meckel's cave. You know, Meckel's cave is somewhere where the trigeminal ganglion is present. So if there is any tumor in the Meckel's cave where the trigeminal ganglion is involved, so obviously your trigeminal nerve will be involved. Involvement of trigeminal nerve will lead to the sensory loss on the face. So there will be a complete sensory loss on the face except at the angle of mandible and lower parotid region, because only this part of the face is not supplied by trigeminal nerve, it is supplied by the great auricular nerve. So all I'm trying to say, that could be a different way the question can be asked here, but ultimately they're trying to ask about the great auricular nerve, and all these what I've written here, they're all the questions asked in the different examination in the previous years. So it's important to pay attention to these two major contents of this triangle here.